Hey guys, sorry to have to start with a picture like this. This is where like the ads always get off for like anyone that have this picture, but to me, like I'm not really in this to make the money. I want y'all to have the best experience. So sometimes in order to truly understand an amputation, you have to understand that a lot of times it looks like this before, which is why we need to cut it off. So an amputation, this is really not a disease process, it's a procedure. And it's where someone has to have a removal of their limb. And usually, like in this beautiful picture, it's due to infection or it's due to dead tissue. And so, at the end of the day, we really think about those people that have issues with blood flow to their feet, like when we talked about peripheral artery disease, or people that are more likely to get infections or not be able to feel it if they have an ulcer on their feet, like PAD or diabetes. And this is where people really, the reason I have arterial underlined here is it's not people with vascular disorders, it's people with arterial issues. Remember, people with venous problems, like this is not an issue. Like think of people that have like blood flow issue problems, like ischemia. Don't think about just people with vascular issues because venous people wouldn't have the same issue. There's not like dead tissue that results. They do have accumulation of like, edema and stuff in their legs and they can get ulcers, but they usually don't get ulcers to the point where they need, their legs cut off. We're talking about arterial problems, blood flow problems. I am not getting blood flow to my feet. So therefore, the tissue dies and then we have to cut off because we don't want that dead tissue to spread. And so, again, anyone who's prone to infection, can't feel their feet, is prone to problems on their feet, like diabetics, arterial disease, they're going to be more at risk for this. I feel like there's something else I wanted to say, but effectively, I think I covered that pretty well. Yeah, I think I've summed that up well, so I'm not gonna harp on that. So it's either people that have arterial problems, diabetes, or in the younger population, amputation can also be a result of trauma. So you might want to think about people in the military, or young males are more likely to get in trauma accidents, have severe injuries that might require an amputation than females will be, but it's an equal opportunity world for some of us. So, but yeah, you want to think about people that have lost flow, lost complete function of a limb, got a bad infection that's spreading in their bones or in their feet. They may need an amputation. So, what are my priority assessments and everything pre and post? So one of the big things that I want to assess for is pain. So both pre and post. Before, if someone has an issue where they have decreased flow to their feet, it could be one of two ways. They could have paresthesias, numbness, tingling. They could have extreme pain because it's infected. It's really painful. They could also have no pain before because of the neuropathies. They could have no pain because there's zero flow. And if there's zero flow, they can't feel it. And so it just depends on the patient. It depends on their other history. If they have diabetes or very severe peripheral artery disease, they may not be able to feel it. But again, on the opposite end, it could be infected, very painful, or if it was a traumatic cause, it could be very painful as well. So we want to assess for pain. That's going to be a big part of this person's recovery before and after their amputation. After the procedure, we're going to assess for phantom limb pain, and we'll talk a little bit about this later. But phantom limb pain is effectively where a patient can no longer have their limbs. This is after the amputation, but their mind has not yet accepted that limb is no longer there. So they're feeling pain. Like they'll say, like, "Hey, my foot is hurting," but their foot is actually not there anymore. Now, to their brain has not connected with that foot no longer being there. And so it's still in its mind, it is feeling like sensations or getting nerve signals from that area, even though they do not exist anymore. So it's interesting. It's very powerful how the brain works. I don't know if you've ever seen those videos, but there's those cool videos where they'll sit there and they'll have like a fake hand and then the person's real hand, but if they stare at the fake hand long enough and they're like stabbing or doing something crazy with this fake hand, they can eventually convince the body that the fake hand is the real hand just by looking at it. Like your mind is a very powerful thing. But anyway, we'll talk more about that later. So we want to assess after for their pain as well. And we'll talk about what to do about phantom limb pain after. So anyway, we'd also want to look for signs of infection. So this would be, of course, we want to do this before and after. Before, we definitely would expect, depending on the cause, signs of infection. So we want to think about what would that look like? You know, they might have purulent drainage. There could be dead tissue, like that black eschar, I think is how you say it. And so they can have the dead tissue. They can also have what do you call it? They can have a fever or systemic signs of infection, really tender redness, swelling. A lot of that can be a sign of infection as well. So just kind of visually looking at it, maybe looking for, oh, I guess I have diagnostics down there, so I'll wait for that. But like I have down here, white blood cell count, stuff like that. We want to check their neurovascular assessment and oh, sorry, signs of infection after. Of course, we want to look at their incision site for any, you know, drainage, any issues, the same stuff, systemic infection, or signs of infection around the surgical site. Before and after, we want to look at their neurovascular assessment. You know, before, you know, how low does their flow go? So like usually with patients like this, let's say that I know they're about to get an amputation. They have no pulse in their foot. Then what do I assess? Well, I'm going to assess the next highest up. So I go behind their knee and I do a, what do you call it? I'm assessing the pulse that's under the knee. I don't know why it's evading me right now. Not why it's not posterior, the posterior tibial there. I don't know why. Oh, popliteal. There it is. Popliteal. Yes. Yes. Yeah, I'm not crazy. It's popliteal. In my head, it was trying to convince me I was wrong. And if I am wrong, and maybe I'll make a correction later, maybe not, but I'm 99% sure it's popliteal. But it's just evading me for a minute. So popliteal, let's say that they're gonna have an above the knee amputation. Then I'll go all the way up to femoral, or femoral, however you like to say it, pulse, and feel for that one. So effectively, I want to check the closest pulse to see how far down their flow is. I'm also going to look for color and temperature changes, that sensory function, all of those 7 P's and 1 C that I had on the other video. And like I mentioned after, and so we do that before and after. So if before, you know, I'm just seeing how far their flow goes. After, let's say they had a below the knee amputation, then I would do that popliteal to see how their popliteal pulses behind their knee. And then after that, if let's say they had the above the knee amputation, then I would be checking a femoral or femoral pulse. Then after the procedure, like I mentioned, you also want to assess the residual limb. And you know, your book refers it to residual limb or stump, but I have heard I had a student who had an amputation, and they said that the, you know, politically correct term or the way to say it is residual limb, and I think that is preferred. Most people, you can always ask a patient and see what their comfort is around that, but residual limb is probably a better way to say it. But you want to assess their residual limb, their incision site, and look at it. We'll talk more about what it's supposed to look like, what we're going to do with it. Then diagnostics, aside from looking for infection, that white blood cell count, we also want to look for perfusion. So they might do Doppler studies to see how low the flow goes, or how long your flow is. Where does it stop, if it stops at all? And they might also get a culture of the wound if they, you know, this is usually pre-amputation, where they're going to see like, hey, they're confirming there's some sort of infection or something else present in that limb that needs to be amputated. All right. Ooh, here is a select all that apply, your guy's favorite. So it says a nurse is caring for a client after a below the knee amputation. Which assessment finding would warrant a call to the healthcare provider? Select all that apply. All right, so let's see. So it's really saying like which of these are warning signs or which of these are problems after an amputation. So the first one says mild edema in the residual limbs. The word mild already doesn't stand out to me because mild is usually something not too serious. But is it okay to have some edema in the residual limb? Well, they just, you know, they just cut off part of the limb and they've had surgery. So I would think there would be some edema present. I'm going to go with that. Does not require a call to the provider. So not A. Dime size sanguinous, which means bloody drainage on dressing. So this always gets students because they say, ooh, bloody drainage, have to call the doctor. But here's the thing, they're going to have some drainage. Usually after a procedure, they might have a little bit of drainage. It's dime size. So you have to think about the size of a dime. And if it's dime size, small little drainage on the dressing, yeah, from perspective of a nurse, what we normally would do with something like this, like if I get a patient from the operating room and they have some sort of drainage on their dressing, what I usually do is I mark it. Like I'll put I'll get a marker and just draw around it. And pretty much I'm just marking that I recognize here's where it starts. Like, this is like the extent that they have the drainage. If it's getting more, now we do want to report bleeding, but if it's just dime size, it's a small size, that might be expected. That should be, or I should say, that is expected after surgery. Just a little bit of bleeding, but if it's extreme bleeding, I would definitely be concerned. But right now we're just dime size, so that I'm not going to call the doctor and say, hey, there's a little bit of blood on your dressing. We definitely will call if it gets worse. Moderate pain in the residual limb. Well, one of the biggest things we're going to be managing after the surgery is pain. And so having moderate pain is actually very expected. They can actually have some pretty severe pain. Now, if their pain is unrelieved, not getting better, getting worse, we definitely want to report that. But just having moderate pain after an amputation, that's going to probably be expected. So far, I don't have any reason to call the doctor. Let's look at D. Small amounts of purulent drainage from the site. Now, you might see that small and you're like, it's not that bad. Is it ever okay to have purulent drainage from an incision site? What do you think? Yeah, this is why my clinical students hate me, because I sit there and I just answer, and they're like, I don't know. And I'm just like, well, what do you think? So yes, I can sit here all day. So the answer is no, it is never okay to have purulent drainage. Like there's never like, hey, you might have a little bit of pussy drainage, or it's normal to have pus coming out of this, fresh incision site. There shouldn't be, because that's a sign of infection. Sorry, my ear just popped. Yeah, so with purulent drainage from the site, even if it's small amounts, that's a sign of infection. I'm going to need to let the doctor know. The last one, so D, I'm going to say yes. Not that I like it, but then I need to call someone. The last one is client's hemoglobin went from 10.7 to 7.1 in 24 hours. That's a pretty big drop. And even though they can have a drop after surgery, that big of a drop, and then also down to 7.1, that's like borderline for giving blood. The doctor may want to do something or do some further testing just to make sure that they're not having severe bleeding. So this is also another reason I would call the doctor. Effectively, after amputation, I'm looking for signs of musculoskeletal problems. I'm looking for signs of pain issues. I'm looking for signs of infection. And I'm looking for signs of bleeding. So the correct answers here that I would call the physician about are D and E. So better or worse? What is a sign that a patient with amputation is getting better? And what is a sign that they're getting worse? Of course, they're getting better if their pain is manageable. They're able to move, have good range of motion in their new limb. No signs of contractures. And a contracture effectively is when you stay in one position for too long. It's like your joint gets stuck and it doesn't have as much range of motion. So like if like a finger contraction is like, it would be like my finger is stuck like this all the time. Or if you ever see those patients, those poor nursing home patients, that they're kind of like this and you cannot get their arms to straighten, that's a contracture. But you can get that in your hip, especially is at risk after an amputation. We'll talk about what to do to prevent that. So kind of like what we talked about here, here's all the issues you can have. You can have pain issues, you can have musculoskeletal or movement issues, you can have infection issues, and then you could also have bleeding. I didn't add bleeding in here, but you should also have bleeding in here. That they're getting better or getting worse if there's I don't have it under my worse, but there should be bleeding on here too. So like I mentioned, there should be no signs of infection. Should have minimal drainage. I'm going to mark in like kind of circle if there is drainage and make sure that it's not getting worse. You'd look for systemic signs of infection like no fever, and you want a well approximated incision with no purulent drainage. Whereas things are getting worse if their pain's unrelieved, if they are unable to move or developing contractures, if they're having that redness, purulent drainage, or fever, those are all going to be signs of infection. Or like I mentioned, if there's signs of bleeding, I would also be concerned. So what are we going to do from a medical perspective? Well, we're going to give them mobility support. So they're most likely going to need physical and occupational therapy. When I think of physical therapy, I think of mobility. And when I think of occupational therapy, I think of activities of daily living. And that's kind of the differentiation there. Keep in mind their balance will be off, so I especially want to provide for safety for them and prevent falls in these patients. And I'll talk a little bit more how to do that from the nursing perspective next. I want their residual limb to heal properly. If they're going to possibly get a prosthesis or be fitted for a prosthesis, which is a prosthetic leg or prosthetic arm, depending if it's upper or lower. And keep in mind, most of the time when I'm talking here, I'm talking about the legs because usually this is what we're going to see more often than the arm, but it is possible to have an arm amputation too. But anyway, so a prosthesis is going to be a limb that we could like an artificial limb that's going to take place to help to get back function, get more mobility and things like that. We'll talk more about prostheses in a little bit. We also, to support healing, we want to manage other conditions. So keep in mind, most of these patients, they have other medical conditions that compromise their blood flow or can lead to issues with healing. So we want to monitor their blood glucose. If I take care of a patient who, you know, hey, I got rid of the we got rid of the limb that was like had a bad infection, great. But if their blood glucose still isn't managed, they can end up getting a surgical infection or other things could complicate their healing. To manage the blood pressure by giving antihypertensives or medications to, because like if their blood pressure is too high, it decreases, it can constricted, so it's going to decrease my flow to my extremities. I want good blood flow to my residual limb. And then we want to do other things to manage your peripheral vascular disease if they have it, especially that peripheral artery disease. So think like antiplatelets, cholesterol meds, and then proper bandaging well, which we'll talk about here in a minute. So we talked about this phantom limb syndrome, where effectively their limb is gone, but their brain is still getting signals that they're in pain. So how do we handle this? Well, we treat the patient like what their brain is telling them, that they're in pain. So we treat their pain. We give them medicines because there's a problem with signals coming to their brain telling them that they're hurting. So we give them pain medication. We treat them. We do not sit there and say, oh, well, this isn't real, or just look, your foot's not there. You know, it's very, that's never the answer. You want to always think about what we can do to really support a patient that is experiencing, like, you know, their pain is what they say it is. And, you know, for these patients, if you were in their situation, you would see that they're like, there's no, like, the pain that they have is real, regardless of what you can see with your eyes. Their brain is not connecting with that. This other therapy we can do is what's in this picture, is what's called mirror therapy. If you ever watch Grey's Anatomy, they had an episode where they did this, you know, with, oh, what's her name? The one that was married to Callie. I can't, Arizona. Yeah, Arizona, when she had her amputation. So, you know, what they do is that they either do therapies to help them to recognize that their brain connect, that their limb is not real. So you saw her like in the show, like stabbing her residual limb or stabbing her leg. And, you know, that can help connect to the brain, like, hey, this leg is not, it's not real, and start to connect with that. But the other thing is what's called, that's not like, there's not going to be on the exam, like, tell patient to stab prosthesis. Like, I promise that won't be an answer, but just so you know, that is something that you might see on a dramatic TV show. But more often what you're going to see, and I'm not saying that they never use that, but I've never, they might use that in more extreme cases, but usually we start least invasive first, and the least invasive is to get a mirror. And with the mirror therapy, what you're doing is that you're helping to the patient to like make new brain pathways for their new residual limb, and helping their it helps their to look at it in the mirror, helps to the brain to connect that limb is not there anymore. So there's a lot of studies that show that mirror therapy can be helpful. So yeah, then like I mentioned, proper bandaging. So we use what's called shrinker bandages. They're like, kind of think of them like compression socks, but it's helping to mold the prosthesis. We don't, there's some edema and stuff after they have these surgeries. They also can sometimes wrap in like an ace wrap or do like a figure 8, wrapping and stuff like that. But there's a variety of different bandages that can be used, whatever the doctor's preference. But just think that we do want good compression, because compression not only helps to shape and mold so that they can fit into a prosthesis better, but it also, by reducing edema, there's going to be less pain. It helps the residual limb to heal better, and really helps with a lot of their uncomfortable symptoms as well. So it's not just about fitting into a prosthesis, it's also about decreasing their pain, their edema, and other symptoms. So I just found this video on YouTube that kind of talks about, this lady shows how to put on shrinkers and stuff like that. If you think that that would help you, you can feel free to watch that. So let's talk about prosthesis. So not everyone is a candidate to get a prosthesis. This is a picture of one here in this picture. You know, in order to have a prosthesis, someone has to be able to have the physical capabilities to do it. They have to have a, you know, a pretty, not, it doesn't have to be perfect, but a pretty smooth post-operative period, because there can be a lot of complications after having a, what do you call it, with an amputation, after you know, with healing and stuff like that, if there's any healing issues, because again, they might have healing issues just because they're also diabetic and we can't get their blood sugar under control and stuff like that. So they have to have a good healing. They also have to have, you know, be of an age or a physical capability in order to you know, keep up with the prosthesis. It's not as simple as just like, oh yeah, you know, what do you call them? You know, anyone could do it. It has to be someone who has good upper body strength, and it also has to be someone who has the energy abilities. Because I didn't know this. Your old book might have said it, but now the new book talked about that. I think for a below the knee amputation, it requires using a prosthesis requires 40% more energy than any other person. And then for someone who has above the knee amputation, using a prosthesis requires 60% more energy than just regular walking. It's definitely not for everybody. For some patients, just using a wheelchair, it's more realistic, it's more safe, where they're going to spend their energy. It also can take up to 3 months to put full weight on the prosthesis. So this is a slow, gradual process. This is not an overnight process. You want to teach a patient that does have a prosthesis not to get the leather and the metal parts wet, and then also to consider the shoe that they have. The shoe that they have can make a big difference on what do you call them, the quality, wear and tear, and maintenance of their prosthesis. So in other words, if they don't have a good fitting shoe, if they're not doing regular shoe change outs or shoe maintenance, it can lead to problems with the prosthesis. So as the nurse, what can I do? We talked a little bit about contractures. So positioning is really important for these patients. I do not want them to stay in the same position for a long period of time. So I'm going to tell them not to sit in a chair for more than 1 hour with their hips flexed. We pretty much don't want too much. Remember how we talked about in back pain and issues? I like flexion. We're going to be worried about patients with amputations to have too much flexion. We do not want them to sit in a chair for more than 1 hour with their hips flexed, because it can actually lead where they can start to get those contractures in their hips, because it's kind of like this flexion is kind of like it's kind of more like this. It's going to lead to them having more of a flexion in their hips, which can lead to that contracture. So we actually like them, preferably if they have the physical capability to. Oh, it's my son singing. I thought he was dying. What do you call it? To lie on their abdomen or lie prone. So this is like the opposite of what I said for back pain, but it's good for amputation. Lie on their abdomen 3 or 4 times per day, or prone. So like lie face down for 30 minutes. So you think about, like, if they're sitting in a chair, like, you know, they're kind of in this position, but if they're lying prone, I can't even do it. Nope, I'm not gonna be able to do it. I can't do a split with my fingers. You know what I'm trying to say? Lying prone, it forces their hips to stretch in a different way. So it can help prevent those contractures. We also don't want them to dangle the residual limb, because it can create edema. You know, we don't want dangle. And remember, dangle is like down. So like, you know, we don't want them to dangle the residual limb for very long periods of time. However, you may be saying, okay, so we want it elevated. We don't. So again, you know, you're going to see this, by the way, you're going to see this in the hospital. Almost every patient I've ever taken care of or seen with amputation, the doctor will put an order in, put a pillow under their extremity. But in nursing school world and in perfect textbook world, we do not elevate residual limbs after an amputation. So just know this. You can I was a tech for 10 years before I became a nurse, and it was so frustrating in nursing school when I would like go to a test and I'd be like, oh, I saw this week, this is what we did, and then it would be like, but in perfect nursing school world, and I was like, oh. So yes, it's no fun, but such is life. This is the textbook answer: no pillows under the surgical extremity. If you're wondering the why, it goes back to the same thing about the hip flexion. If I have their leg raised, it's going to create more flexion in my hip, which can lead to a contracture. We also want to support hygiene and prevent infection. So I want to teach them. I want them to know what the signs and symptoms of infection are because they're going to be high risk. They maybe just had a limb that had to get removed, or part of, sorry, not a limb, part of their limb removed, maybe due to infection. So they need to know those signs and symptoms so we don't have continued. Because sometimes what we do with amputations, they might start below the knee, but then sometimes infection can spread, and other, like if they didn't get enough, or they should hopefully. It's not like they chance it. They're like, there's still a little infection, but we'll just cut this little bit out. They usually cut above where their infection is, but it is possible that it could spread before they're able to get to the amputation. So just be looking for those signs. And remember, all these patients, they usually have peripheral vascular or arterial disease, or they have diabetes. So they're going to be higher risk for infection. Most of these patients, not all of them. We want to teach them hygiene with their residual limb. They should wash it with warm water and soap, pat dry. I'm very gentle with the limb. No lotions, no alcohols, no powders to the residual limb. So treat it a lot. Think of it like diabetic foot care. We don't want to add a lot of extra to the limb. We don't want to mess with the skin. And when it says no alcohol, I'm not talking about them drinking. I'm talking about like rubbing alcohol or like cleaning the incision with alcohol. They also need to clean change their residual limb sock daily. Regularly be changing, washing those, and making sure, like, whatever they're washing them in, that's not going to be too hard on the skin. But yeah, pretty much, be looking for all those. It's those 4 things we talked about: pain, mobility, infection, and bleeding. That's what we're going to be focused on after this amputation, and teach them all the things so that they can recognize and prevent it. Oh, speaking of preventing amputation, and by the way, I know this joke is horrible. Above the knee, below the knee, below I get it. Okay, hopefully you get it. If you don't, and I have horrible humor, and I'm very sorry if it offends anyone most of the time. So how can we prevent amputation? So manage the chronic conditions. So managing the blood glucose, so managing diabetes, managing blood pressure and cholesterol can also help because that improves blood flow or good vascular flow. Teaching the patient how to do foot care and to find these things. The earlier we can catch if there is like an ulcer or some sort of infection in the foot, maybe the decreased chance they're going to need an amputation or more of an amputation. Proper hygiene to prevent infection is key too. And then of course, teaching them signs and symptoms of infection. And then for trauma, of course, to prevent trauma, just safety precautions for work and leisure, safety devices and things like that to prevent injury or to decrease their risk. And also the riskier your lifestyle, you always have to be careful. I'm not much of a daredevil. Just teaching nursing is pretty is pretty exciting in itself. So I think I get all my excitement in my day-to-day, but I'm just educating people on the risks of the choices that they make in their life. All right, getting into fracture. So much fun. See you for that one.